Carty. Professor Carty is chief of the Division of Endocrine Surgery. Is full professor of surgery at the University of Pittsburgh School of Medicine, co-chair of Hillman's Cancer Center, multidisciplinary thyroid cancer, and co-chair of the endocrine genetic clinic, and director of the endocrine surgery. Professor Carty, she is president-elect of the American Association of Endocrine Surgeons. So we know Professor Carty, he's international well-known in endocrine surgery. So we are very honored to invite her, give us the lecture, talk about the definitely management of primary hyperparathyroidism, the guideline of AAES. So Professor Carty, please.
Yeah, just one word. She is also one of the 9 IAES council members.
President Wu, Professor Lee, everyone, it's a great honor to be here today. Thank you for asking me to speak. And I'd try to leave room at the end for questions. So, I have no conflict of interest to disclose, and none of the authors of the AAES parathyroidectomy guidelines had COI either. I'm going to go over today the highlights of the American Association of Endocrine Surgeons guidelines for definitive management of primary hyperparathyroidism, which is a big formal title. What I'm not going to say on slides is why we needed to do these guidelines. We needed to do these guidelines because in the United States there were increasing problems with too much parathyroid surgery, high failure rates, careless follow-up, and confusion about whether asymptomatic patients should get surgery. So I'm going to say that in a very positive way on the next slide, but I want you to know that we did these guidelines to cohere together and address some problems. We use the word definitive because that means surgical. There is no cure for hyperparathyroidism other than the knife. There were some prior statements on how and when to operate. But there really wasn't much advice from our mentors. This is John Van Heerden, who was not my mentor formally. He's a very famous, wonderful man from Mayo Clinic. When I was a young attending in 1992, I went up to him at one of the meetings and said, "Boy, there's been a lot of new research about parathyroid surgery. You big guys should get together and teach us how to do it." And no guidelines came. He laughed at me. But 15 years later, I found myself leading as AAS president in 2014 an initiative to do parathyroid guidelines. This is the good way to say it, that there was extensive change in surgical treatment, that there was variation in practice, and that there were disagreements about how to do it best. So our target was the practicing surgeon, not the trainee, not the expert, but the community practicing surgeon. And we decided to look at the evidence published in the literature using standard methodology, including the American College of Physicians grading system. And what was unique about this guidelines design is that I said we were going to discuss it until consensus. We were going to discuss it until we agreed. Okay? Some guidelines, for example, the ATA discusses it until there's lack of track changes, until edits stop, until people give in. But no, we discussed it until we agreed, and we each learned a great deal from each other. It was fun. The ACP grading system grades a recommendation as strong, weak, or insufficient. and gives it a strength as high, like a randomized control trial, moderate, or low, which is potentially by a small series or case studies. And this is the writing group. Here's the beloved Kwan Du, and this is James Lee. He was one of the three main first authors. This is Nancy Perrier, Janice Pasica. Dan Ruin was another first author or main author, and Scott Wilhelm was the first author. And these people couldn't be there for the photograph. This is Rob Utelsman, who I'll talk about in a minute. Mitch Tublin was our radiologist. Am I doing it? Oh, thank you. I'll just do it like this. Okay. And this is Sylvia Asa from Columbia University, who was our endocrinologist. And I picked her based on the recommendation of colleagues. I was afraid that she would disagree with us about managing asymptomatic disease. It turned out great. She completely agreed with us. So that was brilliant or helpful. And the writing process was that first we got feedback from an independent group of non-author experts. Next, we got input from AAES members and other sources, then journal peer review. And it took us not very long, 2.5 years, to do de novo guidelines. This legal language is obligatory in the United States so that the authors and the AAES don't get sued if any patient should have a bad outcome from what we are proposing. And this picture, I'm going to show it 3 times, was drawn by Rob Utelsman, who in his spare time is an artist. He was the chairman of surgery at Yale, and this became our beautiful emblem. I'll talk about it again later. And here's what I'm going to cover briefly now that you're falling asleep after lunch. 1, provide a current understanding of the epidemiology and pathogenesis of primary hyperparathyroidism. This is the abbreviation. So, as you all know, there's an age-related incidence in hyperparathyroidism that's rising in the United States. Females are affected 3 to 1, and lots of operations to do per year in the US. And the disease can have 3 forms: sporadic, acquired, and inherited. In sporadic hyperparathyroidism, 85% of the disease is from a single bad gland, and 14% is from multiple bad glands. And it's this 14% that had begun to be ignored by parathyroid surgeons in our country, who instead were just taking out what the x-rays showed. And x-rays don't show you multiglandular disease very well, as I'll say in a couple slides. These are some of the familial syndromes, inherited hyperparathyroidism, that are associated: MEN1, MEN2A, jaw tumor syndrome, and MEN4. And this is a summary, this slide, of the recommendations associated with epidemiology and pathogenesis. 1, you should take a family history looking for hyperparathyroidism. 2, if there is a positive family history, you should get genetic counseling, consider genetic counseling, and if the patient is young with multiglandular disease, you should get genetic counseling. This recommendation, which is strong, moderate, says that multiglandular disease affects 15% of patients and should be routinely considered. And that's probably one of the important themes of this talk. And then exposure-related and genotype-phenotype correlations predict anatomy. Now, I'm going to digress and say, how do you recognize MEN1 in patients who you think have sporadic hyperparathyroidism? And this is a paper that my colleague Lin-Hua Yip, who's from Hong Kong, wrote when she was my fellow. She's now famous all over. And these patients, 939 patients, were referred to us with sporadic disease. And when we asked them, do you have a history of MEN1, they almost all said no. But when we asked them the 6 questions, what are the 6 questions for MEN1, it turned out to be a very effective way to diagnose MEN1, which is really common in the Pittsburgh area. Does anybody know what the 6 questions are? It's really easy. No? Do you have a blood relative with a brain tumor, a pancreatic tumor, neck surgery, high calcium levels, kidney stones, or ulcers? That's it, one sentence. You ask these 6 questions, and if the patient says yes to any of them, it raises the risk of multiple endocrine neoplasia type 1 by 7 times. If in an additive way, the more yes answers, the more likely the risk of MEN1 is. This is Nancy Perrier's slide of forearm parathyroidism in MEN1. I'm just going to finish up with MEN1 before I go back to the recommendations of the guidelines. Here's the striated muscle, and here's the parathyroid tissue that's extending into the fat around it. Forearm parathyroidism is one of the reasons that the treatment for MEN1 hyperparathyroidism is no longer routine total parathyroidectomy with forearm autotransplantation, but today is subtotal parathyroidectomy instead, plus or minus cervical thymectomy. So the recommendation from the guidelines to manage MEN1 when it's present is subtotal parathyroidectomy as the index operation. This is in the States. You know, this is not necessarily how you will want to manage it, but we got to be very bossy. Sorry. Okay. So what we teach residents, and I see that there are probably some trainees in the back of the room, is that there are 3 steps when a new parathyroid patient comes to clinic. Number 1, do they have the diagnosis? 2 more steps on subsequent slides, but let's talk first about, do they have the biochemical diagnosis? Or, as said in the guidelines, outline the diagnosis and the clinical manifestations, and then look at the indications for surgery. In the guidelines, we were very careful to say that hypercalcemic hyperparathyroidism is the way that the condition is diagnosed. It's diagnosed based on labs, and the labs show an elevated calcium level. Why do you have to have multiple elevated calcium levels? Because if the tourniquet's up for too long, the arm gets acidotic. The acidotic pH makes the blood calcium level rise. It's a false positive result. So that's why every chapter in every textbook says check the calcium level repeatedly and make sure it's elevated more than once. And people had lost track of that truth. In normal calcemic hyperparathyroidism, it's an increasingly common diagnosis in the US, but actually most of the time it's a mistake. So normal calcemic hyperparathyroidism is an incompletely characterized variant, often confounded by vitamin D insufficiency. And nowadays, we routinely check the calcium, the PTH, and the vitamin D25OH. All together, it's called a parathyroid panel, because we want to exclude patients who actually have just simple vitamin D deficiency, which is endemic in the United States, now, especially with sunscreen and computers. We don't get enough sun, and so we're all vitamin D deficient. This slide, and I'm going to show it twice in this talk, this is right from the guidelines, and it shows some of the common secondary causes of elevated PTH. Chronic kidney disease, medications like hydrochlorothiazide, bisphosphonates, hypercalciuria, this is FHH, secondary to renal leak, gut malabsorption, patients who have chronic diarrhea syndromes, are chronically vitamin D deficient, their PTH is elevated, their calcium is normal, they don't need surgery, they just need a doctor. Okay? And vitamin D insufficiency. And when I see a patient with a normal calcium and an elevated PTH, and I see them all week long, half my clinic is patients whose doctors say, well, do they need parathyroid surgery? Cardi will decide, okay? The treatment that we use is to give them vitamin D. Even if their vitamin D level is insufficient or slightly low, we want it to be robustly normal, right? Because the vitamin D normal curve is based on the bell-shaped curve of the population, and we're all vitamin D deficient, right? So we want a robustly normal vitamin D, and if you give them vitamin D burst therapy, which is 50,000 units a week for 8 weeks, it either normalizes the PTH and then they don't need surgery, bye-bye, or it elevates the calcium and now you have a diagnosis and you can operate. So it's a very good provocative way to resolve this ambiguity. We use it all the time. And here's a slide that says that same thing. For a high PTH with a normal calcium and a low vitamin D, provocative vitamin D repletion to exclude or diagnose primary hyperparathyroidism is super helpful. I had sort of learned this, but when Shani Silverberg on the guidelines said, oh yes, of course, and taught us all about it, it was a big learning experience for everyone. So here's a quiz. Does this patient have hyperparathyroidism? The calcium's elevated, the PTH is high normal, and the vitamin D is robustly normal. Yes, they do, because this is called inappropriately unsuppressed PTH. It's the high calcium that makes the difference, that matters, okay? And the next step is to rule out FHH and get a careful family history, and if they have a personal history of kidney cancer, you'd get a PTH-RP, not very often. Does this patient have hyperparathyroidism? Calcium's normal, the PTH is elevated, the vitamin D is low. What is this? Vitamin D insufficiency till proven otherwise. And that's all I'm going to say about that. So the guidelines agree with current endocrinology medical workshop statements that say that in the initial biochemical evaluation of suspected primary hyperparathyroidism, you should get a calcium, a PTH, a creatinine, and a vitamin D level. Strong, moderate recommendation. And that surgery is indicated when the calcium's at least a milligram per deciliter above normal, regardless of whether symptoms are present or absent. So we agree with what everybody said so far, but as surgeons, we have more to say. So let me ask you this. Is osteoporosis a symptom? No. People don't say, oh, my osteoporosis is hurting me today. Okay? Osteoporosis is a disease. It's a feature. It's not a symptom. But in the medical literature, osteoporosis somehow got called a symptom, and then people got very confused. What we talk about instead is the features of hyperparathyroidism, and here are the features, all of them listed, and this same slide shows in green the ones that get better, the features that get better with parathyroid surgery. Osteoporosis has been shown to improve, kidney stones have been shown to improve, ulcer disease, arthritis, bone pain, muscle pain, fatigue, disordered sleep. There's people with disordered sleep at the back of the room right now. Weakness, depression, anxiety, short-term memory loss, even constipation, something as vague as constipation, has been shown to improve with parathyroid surgery in some patients. And cardiovascular disease, I think we're going to hear a paper about that soon, today. This is erectile dysfunction. Even erectile dysfunction can get better with parathyroid surgery, according to Cardi's paper from 2 years ago. Okay? This is Janice Pasica's data collection form, which she named after herself, the PAS form. And we use it in every patient before and after surgery because they filled it out and they mark here. Here's the patient's mark. I have lots of bone pain. I'm feeling tired today. I'm feeling depressed today, but I'm not having very many mood swings. And they fill it out before surgery and 1 week after surgery, and then at 6 months. And here's the follow-up data from 6 months. Look at this. The patient had polydipsia pre-op. They don't have any post-op. They had headaches, migraines in particular. Pre-op, they don't have headaches anymore. They had bone pain. The bone pain got better. So we use this to remind patients how bad they felt before surgery, because it's human nature to feel better and forget about it. When you've had the flu, you don't remember how sick you were a month ago. We use this form in every patient. Familial hypocalciuric hypercalcemia is something that's pretty common in the US. And so even in patients whose calcium is 11 or 12 or 13, we routinely check for it because its frequency is low preoperatively, but its frequency is high during failed parathyroid surgery. So it's one of the main causes of failed parathyroid surgery, and I don't want any failures. Its hallmark is low urine calcium and a low fractional excretion of calcium. The only morbidity of FHH is unnecessary parathyroid surgery, and if you suspect it, you have to stop hydrochlorothiazide and work them up off of the diuretics after you've repleted vitamin D. So the guidelines concluded, as far as indications for parathyroid surgery, that if you had no changes, if you had a fragility fracture or a high calcium or renal impairment or kidney stones or osteoporosis, or you were under age 50, you should still have parathyroid surgery, no question there. But we also concluded that for so-called asymptomatic disease, you should consider surgery anyway. And Nancy Perrier in particular has done several high-quality randomized controlled trials showing improved neurocognitive symptoms with parathyroid surgery. So for so-called asymptomatic disease, the guidelines said you should get an abdominal KUB to look for silent kidney stones. This is from the endocrinology literature. And you should think about surgery for patients who have cognitive or neuropsychiatric symptoms, or even think about it if patients have cardiovascular disease that might benefit from mitigation of potential sequelae, although the evidence for this is not strong yet. The non-traditional symptoms of muscle weakness, diminished functional capacity, and abnormal sleep should be considered, and reflux and fibromyalgia are too new to make a clear-cut recommendation about. This is a famous, does anybody know this? This is the Peanuts 30 years of comics. And this is Lucy from Peanuts, and she, this is Snoopy, and she offers psychiatric help for 5 cents. The doctor is in, but he just gives friendly advice. The advisor is in, okay? We're talking about cost efficacy. And parathyroid surgery, there's good data that it's, in the US, more cost effective than observation or Sensipar, cinacalcet. So the recommendation here is that surgery is more effective and cost effective than either long-term observation or drugs. Okay, so here's the second steps. Number one, do they have the diagnosis? Number two, it's really hot in here. Number two, can the patient safely tolerate the surgery? I want to say that neutrally, but what we actually say in clinic, in slang, is, are they a train wreck? Okay? Because if the patient's too sick for the general anesthesia, then you don't need to offer them parathyroid surgery, and you don't need to go to step 3. Step 3 is, finally, what does the imaging show? We don't get imaging until we've got a diagnosis and a plan for surgery. That's what this third goal is about. Some of you probably remember Dr. John Dotman, who was the radiologist at the National Cancer Institute years ago, a very smart, kind man, whose statement that everyone quotes, this is where the quotation comes from, the only localization study indicated in a patient with untreated primary hyperparathyroidism is the localization of an experienced surgeon. Okay? No longer true. Today, we obtain imaging after we decide to operate, and we do it to do operative planning. The guidelines also conclude that based on the data, imaging done at a high-volume center is more likely to be positive, and it's significantly less accurate in multiglandular disease. This is a SPECT CT, the kind of imaging that I routinely get when I operate at the mothership, my main hospital. And it shows a parathyroid focus right here. But when I operate at the outside hospital, which doesn't have intraoperative PTH monitoring and doesn't have SPECT CT, I don't get anything but an ultrasound because I want to have integrity. I either do a bilateral exploration if those resources are not available, or if I'm doing a selective minimally invasive procedure, then I get all this imaging. The main point is that, let's see, cervical ultrasound is recommended to localize parathyroid disease and assess for thyroid pathology. 4 patients out of 10 are going to have thyroid pathology. And I said this earlier, you should get to decide your own kind of imaging because you know best. And then in the United States, we had to say, patients with negative imaging are still surgical candidates and should be evaluated. Just because the imaging's negative, you still should operate if they have the disease. Negative imaging means that the failure rate of surgery is slightly higher and the risk of multiglandular disease is higher, but you should still operate. Okay, so here's this picture again to remind me to say that eutopic and ectopic parathyroids can be all over the neck and upper chest. And the parathyroid surgeon really has to be an artist to discover where they're living and to explore and find them. But nothing is happening. Here we go. As far as preoperative management, the guidelines say that most patients should take regular amounts of calcium, that it's safe for them to get vitamin D supplementation if they're deficient, and that we should avoid parathyroid biopsy when we can. Why is that? Because under the microscope, the needle makes the biopsied parathyroid gland look like cancer. Additional voice evaluation should be performed if there are significant voice changes or prior at-risk surgery. Okay, this slide is to remind me to stress that operation is all the way over here and reoperation is completely different, apples and oranges, okay? So initial operation, you don't need any imaging if you're going to do a bilateral exploration, or you can get an ultrasound to look at the thyroid. But for reoperation, you need all your tricks, because the risks of failure and hypoparathyroidism and nerve paralysis are higher with reoperation, as well as the costs. Okay, initial surgery for sporadic hyperparathyroidism. This is a busy slide, but it basically says you can do either one. You can do minimally invasive surgery or bilateral exploration. Either one is fine. The point is that in the literature in 2013, there were 75 different definitions of minimally invasive parathyroidectomy. So what did the guidelines decide? That minimally invasive parathyroidectomy just means routine use of imaging, a short incision, and focused dissection. And that minimally invasive surgery increases the use of adjuncts as well. Thanks. I just feel bad for it's hot in here and it's making people sleepy. I know I'm boring, but okay. So bilateral neck exploration is still the gold standard. It's the operation of choice when you suspect multiglandular disease. In other words, as the recommendation says, planned bilateral exploration is the preferred strategy when there's discordant or non-localizing imaging, there's a high suspicion of multiglandular disease, when IOPTH is not available, or if that's just the way you prefer to do it. It's perfectly okay to do a routine bilateral exploration. We have said all of these things. This is how I do parathyroid surgery when people are skinny, which is not always the case in America, and when they have single focus concordant imaging without goiter, okay? And this is Palomicali's procedure, video-assisted parathyroidectomy. This is a special sucker with a Q-tip in it. Here's the view inside this person's wound as the adenoma comes into view. This is the adenoma. And here we're putting a clip on the vascular pedicle. And this incision is only 2 inches long. Is this the obligatory way to do it? No, this is a marketing tool. This says, I know what I'm doing, so you should come to me for the surgery, right? Because your incision will be even shorter. But it has the same results as a routine bilateral exploration done through a 4-centimeter incision. It's just one way to skin the cat. The guidelines thought a lot and looked a lot at all the data on intraoperative PTH monitoring, and some of that data is from my program. When George Irvin invented the technique in 1994, he had trouble getting his papers published about it. And so he said to my senior partner, and I was just a sweet young thing, he said, I need somebody from a different program to validate my technique. And so we did the validation study for Irvin's technique, and I presented that in 1997 at the AAS meeting in Baltimore. And you could have heard a pin drop because everyone was dying to decide whether to start using PTH monitoring. The punchline is that imaging tells you where to start looking, and IOPTH results say that you can stop looking. Or the results of bilateral exploration say that you can stop looking, because what is the point of parathyroid surgery? Cure. You want to cure the condition. So when we use intraoperative PTH, we draw a systemic level from the foot. We use a lot of blue gloves to do it. And we use an intraoperative data form. Here, the patient's name is marked out because this is the United States. But this patient had a medium small 223 milligram adenoma, and they had a drop in their intraoperative PTH from 93 to 36, which predicts cure. It doesn't define cure, it predicts cure. And we use PTH wash analysis to identify or to prove the identity of the adenoma. It came back greater than 50,000, confirming parathyroid tissue. So to summarize about how to do the surgery and whether to use intraoperative PTH monitoring, the guidelines don't say you have to use intraoperative PTH monitoring. They just say that when you're doing a minimally invasive operation, you'll have higher failure rates if you don't use it. One of the surgeons on the panel doesn't routinely use it and has a 95% success rate. And the other surgeons on the writing group have a 98 to 99% success rate. So we had to craft this language very specific, very cooperatively. Surgeons who use IOPTH sampling should use a protocol that's reliable in their local environment, and they should be able to troubleshoot when things go wrong. And there's several different sets of criteria to determine an adequate drop in PTH. This is the original criterion of George Irvin, a 50% drop. This is my dual criteria, a 50% drop plus into the normal range. And this is a picture of PTH aspiration, ex vivo aspiration, to identify or confirm or exclude that it's parathyroid tissue instead of a lymph node or an extrathyroidal thyroid nodule. Devascularized parathyroid tissue should be immediately auto-transplanted. And if you think it's cancer, you should notice that and act appropriately. Take out whatever it's stuck to, and then afterwards avoid node dissection and radiation, which have no proven benefit. This is a picture of parathyroid carcinoma. And it shows all the features of parathyroid cancer. It's white, it's stuck to things around it, it's hard. This is a paper we wrote 3 years ago and presented at IAES. And it says, yes, parathyroid adenomas are getting smaller. It's not your imagination. We've taken out all the big ones. Now they're half the size that they used to be 15 years ago, 1.4 grams down to 700 milligrams. The guidelines go on to talk about post-operative management and say that, you know, we had to say this in the United States, that you have to have an operative note that has some detail in it, that you should observe the patient for a certain amount of time for hematoma. We don't specify what that time is. In my program, it's 6 hours. That short-term calcium supplementation can be considered afterwards to try and prevent tingling. Oh, and I want to talk about this in some detail. So this is a bad incision. Okay, this patient happens to have thyroid surgery, but we took this picture in clinic because the scar is not very good. Over here, the scar is really nice. And over here, whoops, the scar is hypertrophic. So what I've learned over 2 decades is that routine, vigorous incisional massage helps prevent keloid, like really prevents keloid. This is a hypertrophic scar that's nearly a keloid. It wasn't itchy, so it didn't quite count. And when I asked the patient to demonstrate how she was rubbing her incision, she was only rubbing the good half. She was only rubbing this half. Okay, so it's a great picture, right? Because over here where she wasn't touching it, she has the standard hypertrophic scar. Routine incisional massage is something that we tumbled to over 2 years of observation. First, I was worried that, the swelling was ugly, so I told them to rub it to get the swelling to go away, and then I noticed that 3 months later, their scars really look good, and then I started telling people to rub their scars, and then I started aggressively telling people to rub. I have a big skin cancer scar right here. You can't see it at all. I rubbed it away. Works on any scar, okay? So if there's a problem with keloid, instead of not touching it, what you want to actually, this is in randomized trials, it's not the vitamin E oil that makes the difference, it's the massage. And we tell them to rub their scar all day, every day for 6 months, and then they come back with something that looks like that. It's pretty neat, okay? All right, the last goal here is to delineate post-operative management, including the diagnosis of cure and failure. Because what do you want to know as a surgeon? Will my surgery work? What do I tell the patient? Did I do the right thing? It's not like taking out the gallbladder that's always right here. It's easy to find, and when you take it out, it's going to, their stones are gone most of the time. Okay? Parathyroid surgery is less clear-cut. The literature says that success in parathyroid surgery is durable normalization of calcium levels at 6 months. Surgery for cure, this is from the guidelines, obligates the use of a validated technique to exclude multiglandular disease. Techniques that are proven to have a high cure rate are bilateral expiration, minimally invasive parathyroidectomy with IOPTH. Unproven or disproven techniques are selective unilateral adenomectomy without IOPTH, and all imaging techniques, including the probe. The probe uses differential radioactivity count to look at sestamibi uptake. And we know that sestamibi scans, excuse me, I didn't include the data in this talk, but we know that sestamibi scans aren't very good at distinguishing single gland from multiglandular disease. So why should a probe based on a sestamibi scan be anything better than the scan? It's a flaw in the reasoning. The literature says that cure after this surgery is defined at 6 months because initial postoperative levels can be misleading. If I drink this bottle of water right now, it'll drop my blood calcium level. And that's what postoperative hydration does. So the 6-month time point is also the accepted standard for determining persistent disease versus recurrent disease. And although normalization of PTH is desirable, it's not required or defined to measure cure. If you're operating for normal calcemic disease, you must also include a normal PTH at 6 months. And I do operate for normal calcemic disease, maybe 1 patient in 100. All right, so we've said that already, and that. Here's this table again. Because 6 months after your parathyroid surgery, if your PTH is elevated with a normal calcium, you want to think about, is this from kidney disease, medications like hydrochlorothiazide, or even Lasix? Is this from GI malabsorption with vitamin D insufficiency? When surgery fails, and it's still the most common operative complication, the failure rate in initial surgery is 1 to 5%, but in reoperation is much higher. And because with reoperation the risks are higher, we have a higher bar to take the patient back for surgery. So the bar to go for initial surgery is low. Sure, I'll do a thorough exploration with a high cure rate, but failure is higher in reoperation, so it requires positive imaging, a preoperative vocal cord exam, and some robust features before the operation. It also needs greater surgeon experience. And we were laughing at lunch because these guidelines were written by experts for a community surgeon. And we ended up saying in the failure and reoperation chapter, send the patient to us, which is not necessarily what you want to say. Here's an algorithm from the guidelines for managing the failed patient. Because 2 of the main risks of parathyroid surgery three of them, cannot be determined for 6 months after the operation: failure, hypoparathyroidism, and nerve paralysis. The SESQUIP database was invented by AAES, and we use it. I think there's 47 programs that use it now, and it tracks your management. We have a person in our office who enters the data, so because I don't supervise her work, her data entries are technically neutral. The literature shows that parathyroid surgeon volume inversely correlates with the risks of failure, hypoparathyroidism, and nerve paralysis, and also with length of stay, with a cutoff of about 50 cases a year. Is everybody in this room who does parathyroid surgery doing at least 50 cases a year? Probably not. So you have to say to your patients, this is something I do all day long. I don't meet the cutoff of 50 cases a year, but my failure rate is X and my nerve paralysis rate is Y. In the United States, and because of these guidelines, we tell patients exactly what our risks are when we book the case. I'm almost done with this part, so hang on. Parathyroidectomy should be conducted by surgeons with adequate training and experience. Surgeons should choose an operative approach that works for them, either bilateral expiration or minimally invasive with PTH monitoring, and that has comparable cost to other techniques, not something that is extremely expensive. And patients with persistent or recurrent disease should be managed by true nerds, true experts. I like to say nerds, though. Okay. Thyroidectomy outcomes also depend on surgeon volume, and this slide summarizes the outcomes data in the United States for thyroid surgery. You do better if you do at least 26 cases a year. That's from Julianne Sosa's paper 2 years ago. You do better if you do at least 30 cases a year. This is from our paper 4 years ago. And you do better if surgeons who do a lot do better. This is from Imad Kandil's paper in 2013. This is UPMC data, and this is really cool. This is published. But what I want to show you is a number of things. At our hospital, we looked at immediate readmission for hypocalcemia after total thyroidectomy by whether you were an endocrine surgeon, otolaryngology, or just a general surgeon. And endocrine surgery is in blue. Otolaryngology is in green. This one's my husband. And he's good. He's a very good doctor. And the outside general surgeons are here in purple. This is case volume. So this tall thing is not me. This is my partner, Dr. Lynn Hua Yip. She's a goddess. She does a ton of surgery. This one's me. And in orange, or yellow, is the readmission rate. And so even though she does tons of total thyroidectomies, she has 0 ER visits for tingling after the surgery. So this is a very informative slide because this is where we got a cutoff of 30 cases a year. And this allowed us to go to administration and say, gee, maybe these two people shouldn't be doing as much thyroid surgery since their volumes are low and their outcomes are poor. They're taking out all the parathyroid glands. Okay? Okay, so now I'm almost done. This is to say, let's summarize the findings of the guidelines. Initial evaluation should include a vitamin D level and a DEXA bone density and a 24-hour urine calcium. Almost everybody should get parathyroid surgery, all symptomatic patients, and if you're asymptomatic, you should be considered for it. You should get to decide, which is different from the medical literature, right? Cervical ultrasound and other is recommended to look for thyroid disease and for operative planning. Even if your sestamibi scan is negative, you're still a surgical candidate. You should always think about the possibility of multiglandular disease and fix it. The intent of surgery is cure. Avoid FNA when possible, and high-volume surgeons rule. 2 more slides. Either minimally invasive with IOPTH or bilateral expiration are fine operations that achieve high cure rates. If you know that it's multiglandular disease, you shouldn't do a minimally invasive operation or shouldn't plan for it. Tissue aspiration can confirm parathyroid identity, and devascularized tissue should be auto-transplanted. And then postoperatively, good care. Cure is defined as eucalcemia at 6 months, and hard cases should be done by experts. And this is Julianne Sosa saying in an editorial, in the end, the community should ensure this is a living document that is relevant and real by using it. And we are in the top 1% of articles in JAMA surgery so far, in terms of being read. Okay, now I'm going to switch gears for 5 minutes on this and 5 minutes on one other thing. When you write guidelines, I wanted to say this at the beginning and forgot. You want to construct a writing panel that's experts, published experts, that conducts good care. You know that they're not out there doing something weird, but you know that they are solid, good care, and people who can get along. You want to have a group of authors who are not going to stand on their reputation or fight. And so the writing group that I had way back at the beginning was people who were chosen in order to get along with each other. And we all learned a great deal from each other. It was fun. It was very valuable, probably like my 4th child. We have 3 kids, and this was my 4th. Therefore, when that works out okay, then you can say to the society, like this society, okay, let's do Taiwan thyroid guidelines next. And I did. I went to the AAS and said, that worked out okay. How about thyroidectomy guidelines? And they said, well, it's too much power for you, Sally, but okay. Right? So I said, okay, I'll do it with a co-chair. And this is the thyroidectomy guidelines writing group, because I wanted to teach the next person how to do it, right? And this is Julianne Sosa. This is my co-chair, Chris McHenry, who's wonderful. This is Herb Chen, Jerry Doherty, who's on the ATA guidelines. This is Dave Stewart from ENT, and Ralph Tofano, you all know, from ENT. And this is our first author, Kapil Patel. So this writing group, this is Virginia Lavolsi, is our pathologist. This writing group, and this is a picture of, like, kind of random there, huh? This is the thyroidectomy guidelines writing group, and next week we're ready to submit this to our new journal. It took a little bit longer to write. It's a bigger group. There was a little bit less of a mandate to write it and a little bit more controversy, but this is our endocrinologist, Jen Sipos, Peter Angelos. It's ready to be submitted. I just said all that. Oh, okay. So then I wanted to say one other thing. It's a great honor to be invited to speak here, and I'm a girl, which is probably not common or typical in Taiwan or in Korea or in most of planet Earth. At UPMC, these are my partners, Dr. Kelly McCoy, who was a lieutenant commander in the Navy and went to Iraq and then came home and had more children. She looks sweet. She's tough as nails. And this is my partner, Lin Hua Yip, who's brilliant, brilliant about molecular testing. Very, very good at data. And even at Pitt, it's kind of weird. It's completely weird to have a division that's all female. It's not, we're the only one. Here, everyone is very gracious and accepting and positive. In the US, when you're weird, like women are, surgeons are not normal, people junior to you think it's normal and it's wonderful. People over you can be very mean. And the three of us have had careers marked by dealing with that meanness a lot. This is a picture that went viral last year. It's called I Look Like a Surgeon. It came off the cover of the New Yorker magazine. And in the cartoon on the cover of the New Yorker, all the surgeons were women. And so among women's groups all over the world, everybody made a picture of their own division. This is our fellow, Janelle at the time. Here's Lynn. This is our other fellow, Kia. I just want to say that thank you for inviting me, because I know it's not necessarily what you're used to. And this is our family. My husband is an otolaryngologist who's also very, very smart and funny. And these are our three kids, and I'm done. Okay, thank you.
Thank you, Sari. Very comprehensive. It's not published yet, right?
The thyroid guidelines are not published yet. The
Parathyroid?
parathyroid guidelines were published in 2016.
Did you ask the Scandinavian experience before you? Did you ask consult the Scandinavian countries, so for example, Sweden, about do they agree with your guidelines?
I don't know. We didn't ask, and I think their experience may have been published after ours, but I'm not sure.
Okay. Yeah, I think I remember in the 1990, we have a first guideline from medical people by Zirikian.
Yeah, Bill Ezekiel.
But first time he called it the guideline, but afterwards, subsequent to consensus instead of guideline.
In 1991, it was a guidelines meeting. I was there. I was a fellow at NCI. And then after that, it became workshops, consensus workshops, right, which were just basically run by him. And he is the one who began to call osteoporosis a symptom, which got into a little bit of a mess what he was doing, and Shani Silverberg was his fellow, is they were trying to be objective about measurable disease portions in hyperparathyroidism, and that's why they called osteoporosis a symptom, because it's measurable, whereas short-term memory loss is harder to measure.
Yeah, we had a survey for the members of IAES. Apparently, only a few surgeons agree with the guideline. Most of the surgeons are doing practice of guideline. Yeah, if patient come to you with the diagnosis, then every surgeon, almost every surgeon agrees to
Good,
operate. Yeah,
good,
yeah.
because you're a surgeon.
Yeah. And finally, medical people invite more surgeons to join in. For example, oral crack in the second workshop.
Yes.
And the third workshop, plus Udersman, Rob Udersman.
So the third,
Kwang. Yeah.
the third workshop, I was Secretary Treasurer of AES, and I wasn't very published in parathyroid, and they asked me to join, and I said no, and suggested Rob and Janice, who were more leaders.
Yeah. As the Sosa said, it's a life. It means they might be changed after a few years, right?
Yes.
Yeah.
Yes.
Yeah. Okay. Yeah. Question from floor?
In your slide, it shows you use quick intraoperative PTH, but you use dual criteria. By your practice,
Yes.
dual, that means 50% more, and also the absolute number is down to the normal. Is that right?
Sort of.
Your criteria.
Yeah.
Okay, that's one question for you. If down more than 50%, but the absolute numbers is still above normal, in such kind of cases, how do you do the next step?
Great question. So, in full disclosure, we don't use the dual criteria as much. We use the 40 picogram per ml cutoff. The dual criteria say 50% drop plus into the normal range. But if you think about it, once you take out a single adenoma, the other glands should be suppressed. It should be less than normal. We just made up normal in the hallway because it didn't seem like the single Miami criterion was sensible. So Keith Heller from Long Island made a paper 5 years ago that said, no, you should use a cutoff of 40 picograms per ml when high normal is 65. And we tested that and agreed with him, and so did Herb Chen's group. So we just sent in a paper to AAES last week where all the reviewers said, change this, change this, change this. And are you using 40 picograms per ml? Because we mostly are. So when the PTH drops by 50% but not into the normal range, we don't stop looking. We'll go to the other side, look for multiple bad parathyroid glands. I had 3 patients this month who had single gland disease on their x-rays and turned out to have multi-gland disease at exploration. All 3 of them, I found other bad glands elsewhere in the neck when I looked. I just didn't stop looking, okay? Maybe an hour and a half. If it drops from high, let's say 90 to 47, do we keep looking? It depends on the size of the first resected gland. If the first resected gland is small, it's called a microadenoma, under 200 milligrams, yeah, we keep looking. And one of those patients did have multiglandular disease when I kept looking. So for me, too much information, but for me, the point of the surgery is cure. It's not to take out mindlessly what the x-rays show. That's not cure, that's being the servant of radiology, okay? And so I don't want failures. I'm willing to dissect on both sides of the neck in order to get that cure.
Here in Taiwan, we have patients without hypercalcemia more than 1 milligram per deciliter above normal.
Yeah.
But the bone mass density is already below 2.5. So, yeah, do you have any comment about the diet? The diet influenced the indication.
As a surgeon, I don't know enough about the diet, but Shani Silverberg would say they're all vitamin D deficient. They're not getting enough calcium in their diet. That's why they have osteoporosis, and she would be able to answer your question. So I can't say more than that.
Taiwan is we have plenty of sunshine, but daily is always cover up. This happens also in Saudi Arabia.
Yes.
You know, Saudi
Yeah.
Arabia is a vitamin D deficient country.
Yeah,
Yeah, that's true.
that's
yeah.
a really good point.
Yeah. So it might be, and our diet, Oriental diet, according to the nutrition,
Well,
it's
when we-
about 80% of the daily requirement. It's low hypocalcemic diet.
When 1,000 years ago, when we ate a lot of bones. Other questions?
Yeah, Dr. Kadi, ask you a question. In a scenario, a woman with a eucalcemic hyperparathyroidism, and I checked vitamin D is low, but imaging study show a big parathyroid lesions. Okay, for you, you treated vitamin D deficiency first, or you just do the parathyroidectomy?
Thank you. That's a really good question. It comes up all the time. I treat the vitamin D deficiency first. Not only does it make me uncomfortable to operate for normal calcemic disease, because what is the definition of cure? The whole thing makes me uncomfortable. Imaging has a very high false positive rate. It could be a lymph node or a thyroid nodule or a mistake. So that's one reason to treat the vitamin D first. And it doesn't take more than 2 months. Give them 2 months of vitamin D burst therapy, see them again in 2 months, and then if they're hypercalcemic, book the surgery. But the other reason to treat the vitamin D deficiency is that their post-op paresthesias are much less likely if they're vitamin D replete. So in the United States, when the patient has tingling at 4 o'clock in the morning or 11 o'clock at night, who do they call? Me. I get the call on my beeper, right? Not a fellow or a resident. And I don't want to get called at 11 o'clock at night. So in order to cut down on, we call them tinglers from the old horror film, The Tingler. But in order to cut down on paresthesias, if you replete the vitamin D first, many fewer phone calls. So we put all patients on calcium after the surgery. We get it from Orlo. We got the recipe from Orlo Clark. We put them on 2 Tums Ultra twice a day, so about 4 grams a day. And we freely increase the dose if they tingle, if they have paresthesias. And I stop it 6 months later because continuing it repletes their calcium and is more likely to produce normal labs at 6 months so that they can get rid of me, not have to come back.
Talking about the vitamin D deficiency, I have to do some studies. I just checked the thyroid patients to check the vitamin Ds in our peoples. I found this, if you cut levels, it's 30. Although we have a lot of sunshine, but we still close to 50% vitamin D deficiency. If the cut level is 20, about 30, still is vitamin D deficiency. So vitamin D deficiency is quite popular even in Taiwan.
And it's been implicated in breast cancer and all sorts of other diseases, vitamin D deficiency. And Nancy Perrier has a paper that says it's safe to give vitamin D preoperatively. It doesn't cause kidney stones, and it doesn't cause a sky-high calcium level. It's safe. So we use it a lot. Yeah.
Do you think the rapid increase the coronary calcium score and the aortic calcification is a sign of hyperparathyroidism?
Aren't you going to give a paper about that next?
Personally, I had my calcium score from 99 up to 300 in 5 years. So I checked my parathyroid. I found that my parathyroid is 105, and my vitamin D is 19 only. I supplied the vitamin D. The parathyroid increased, and the urine calcium increased up to 350. So how to treat it?
One thing about the guidelines in cardiovascular disease is that the Swedish literature shows that hyperparathyroidism is bad for your heart. But in America, maybe it's money, but they don't want to pay attention to that data because then everybody would need parathyroid surgery. So we were happy that we got it in there at all that said you should consider parathyroid surgery for people with cardiovascular disease. I know I didn't answer your question, but...
So far, there's no gold standard of indication for secondary hyperparathyroidism.
Yeah.
Do you expect this will be, you will work on this? Secondary renal hyperparathyroidism.
I'm too old to do they won't ask me. But in secondary, in the U.S., the threshold for surgery is a PTH of 1,000. That's dropped recently to 500.
That's the Japanese criteria.
Yes. And also, to protect the health of a transplant, even before you do the transplant, is a new reason for secondary surgery.
Yeah.
And also, starting the patient on calcitriol, and I didn't write it, never wrote it up, but thought of it myself, and then somebody else thought of it and wrote it up at the same time, really helps prevent bone hunger after surgery. So the person who gave a paper at 9 a.m. today on bone hunger mentioned bone hunger with secondary parathyroid surgery. We routinely give them calcitriol 3 days ahead of time to help prevent severe low calcium after the secondary surgery.
I'm surprised you have such a cooperative nephrologist. Yeah, our nephrologist believes more in chemical parathyroidectomy.
Oh.
Yeah, they use the average IPTH before sending to surgeon is more than 1,000.洪崇杰的 data 是1100啊，我看你那个 average, the minimal IPTH sent to surgeon is 1,100.
You have cooperative patients, though. We don't. So the kidney doctor will send the patient for surgery, but the patient will refuse. I have operated for patients with PTH of 7,000.
7,000.
Yeah.
What happened after operation?
They had really severe bone hunger.
Of course, yeah.
They look like Captain Martens, the picture in the book of the sailor who got all bent over. They look just like that. Other questions?
曾世平你也很多经验了。
I have a question regarding the subtotal parathyroidectomy for multi-gland disease. You will leave a small remnant in one of the gland, right? For subtotal parathyroidectomy. Will you choose the smallest one, either a superior or inferior, or you will choose the inferior gland to leave inside you because the inferior is more superficial and more easier to re-operation?
Great question, thank you. So the remnant's supposed to be 50 milligrams. I don't leave a 50-gram remnant, I leave 100 milligrams. Or if they're really sick, preoperatively, 150. I leave a bigger remnant than I'm supposed to. I have maybe 3 patients who've recurred over the years. So leaving a big remnant is okay. I don't choose, I know you're supposed to do what you said, but I'm too impatient. So I like to start on the right side. I find that gland, I take it out. I find the next one, if it looks like it should be the remnant, I make the remnant, but typically I'm too impatient, and so I take it out and send half for cryopreservation and weigh the other half. And then now I have to find 2 glands here and make one the remnant. So I do the remnant next, like a good girl, right? And then if it's ischemic or not perfect, then I'll use the other one. But I don't worry about the superior, inferior, it's all the same, I think.
Any more questions? Then we have to thank Professor Sari Kadi for this very, very wonderful talk and pass important message to us and answer so many questions. Thank you.